Alina is going to be talking on duration of anticoagulation and unprovoked VTE today.
Yes, so I think I know everybody who's here. I'm just talking today about duration of anticoagulation in unprovoked VTE. And this will essentially be a review of some recent literature that was published by F. Kahn et al. I do not have any disclosures at this time. In terms of the inspiration, so Faison Kahn, he recently completed his PhD, and he did his thesis on unprovoked VTE and sort of how to make decisions around duration of anticoagulation in that context. And it was some quite good research that was published in a number of papers, or very renowned papers. And so I think it is reasonable to go through all of his papers sort of in sequence to get an idea of sort of what this new literature shows and how it may or may not change your thinking in regards to indefinite anticoagulation and unprovoked VTE treatment. So the actual clinical question today is, what is the optimal duration of anticoagulation for secondary prevention in patients with unprovoked VTE? And I will specify that specifically for Faison Kahn, he defined unprovoked VTE to include patients who had minor transient risk factors. And we'll go through that a little bit further. So not at all talking about this primary treatment phase, which is 3 to 6 months, but more so after that and sort of how long that should be in decision-making around that process. In terms of what I'll go through today, first I'll talk about current guidelines. Next, I'll go into the recurrence risk in patients with untreated unprovoked VTE, then the recurrence risk in treated unprovoked VTE to compare, the bleeding risk in patients on extended anticoagulation with unprovoked VTE, and finally, the bleeding risk in patients not on anticoagulation, because that's also not zero. And then just a little bit of time on comparative literature. I actually scaled that part down quite a bit, as I did want to have some time for discussion at the end of this. So in terms of current guidelines, first I'll just talk about sort of 3 main guidelines: ISTH, ASH, and CHEST. So ISTH published in 2012, the guideline talking about duration of anticoagulant therapy after a first episode of unprovoked PE or DVT. And their overall suggestion is that in patients with unprovoked PE or proximal DVT, anticoagulation should be considered for as long as the perceived risk of anticoagulant-related bleeding is not so high as to preclude continued treatment. So not very specific. And they do say in these particular scenarios, listed on the right here, that it may be a stronger indication for considering long-term treatment. So male gender, as we know, they have a higher risk of recurrence, moderate to severe PTS, ongoing symptoms of PE, satisfactory initial anticoagulant control, and an elevated D-dimer result, which is a little bit more of a contentious question. And this is, after completion of anticoagulation. The CHEST guidelines from 2016, guideline number 9, remarks that in patients with a first VTE, that is an unprovoked proximal DVT of the leg or PE, who have a low or moderate risk of bleeding, and they define moderate risk of bleeding to be about 1.6% per year, or having one of the risk factors listed on the right side here. That extended anticoagulant therapy with no scheduled stop date is preferred over 3 months of therapy. And those with a high bleed risk, so those who have 2 or more of the factors listed on the right here, possibly considering a shorter duration. So, 3 months or 6 months over a more of a prolonged treatment duration. They do make a remark that patient sex and D-dimer level measured a month after stopping anticoagulant therapy may influence the decision to stop or extend anticoagulant therapy, which I will go into very briefly later on as well. And then finally, the most recent ASH guidelines that were published in 2020. So recommendations 15, 16, and 17 basically say that for patients with unprovoked DVT or PE, ASH guideline panel suggests against routine use of prognostic scores or D-dimer testing or ultrasound to detect residual vein thrombus to guide the duration of anticoagulant therapy. So a little bit different than chest and ISTH. And then also recommends that after completion of primary treatment for patients with unprovoked DVT or PE, indefinite anticoagulant therapy. So what is the new evidence that has been looked at by Faison Collin and his colleagues? So the first question they asked is, what is the risk of recurrent VTE after discontinuing anticoagulation? So he published this paper called Long-Term Risk of Symptomatic Recurrent Venous Thromboembolism After Discontinuation of Anticoagulant Treatment for First Unprovoked VTE. It was a systematic review and meta-analysis, and it was published in BMJ in 2019. So the papers that he included were RCTs and prospective cohort studies only. And like I said before, it's not just unprovoked VTEs that he included. He also included those provoked by minor transient risk factors. So those are listed on in this box here on the right side. So surgery with GA for less than 30 minutes, admission less than 3 days, estrogen therapy, pregnancy, being confined to hospital for at least 3 days, to been out of hospital for at least 3 days, and leg injury associated with reduced mobility for 3 days. In terms of his inclusion criteria otherwise, they had to have completed at least 3 months of initial anticoagulation therapy before stopping treatment. The decision to stop anticoagulation could not have been guided by clinical decision rules, so it had to be based on other things. And follow-up had to be at least 9 months after discontinuation of anticoagulation to follow up for results. The primary outcome they were assessing was recurrent VTE, and they were able to include 18 studies, which included 14 RCTs, 4 prospective cohort studies, and a total of 7,515 patients with data that exceeded 12 months. So in terms of the actual results from these 18 papers, they found that the cumulative incidence of recurrent VTE at 2 years was 16%, 25% at 5 years, and 36% at 10 years. And these are the common values that we often will tell our patients for those who have sort of unprovoked or minor provoking factors, 36% at 10 years, which is quite high. And, as we know from previous studies, tends to be higher in men than women. So 18%, 29%, and 41% in men, compared to 14%, 21%, and 20% in women, with an overall case fatality rate of recurrent VTE of 4%. And this on the right here is just a forest plot looking at the case fatality rate for recurrent VTE, and includes all of the papers that were included in this study here. And you can see that the majority of the studies here really are previously we're looking at warfarin as opposed to any DOACs, with an overall, like I said, case fatality rate of about 4% overall. It's just going into the data a little bit more here. So this is the second table from the paper. And you can see here that, as we proceed through time, that the risk of recurrent VTE does go down. So the first year is 10.3%. The second year is 6.3%. And between years 3 and 5, 3.8%. And between years 6 to 10, 3.1%. And those are all sort of per year, or per 100 person years. Okay. The fatal PE rate, interestingly, does not seem to go down as much with time, though there is that same trend. So in the first year, 0.4, in the second year, 0.3, in years 3 to 5, 0.1, and 6 to 10, 0.1 as well, with a 10-year cumulative incidence of fatal PE of 1.5 per 100 person years. Okay. In terms of the risk of recurrent VTE after discontinuation of anticoagulation by the site of initial VTE, so he also did a number of sub-analyses. Number one, looking at sex, for which the results we've already gone through, but also looking at the site for the initial VTE. And he did find that patients with proximal DVT did seem to have a slightly higher rate of recurrence compared to those who had isolated PE or who had both DVT and PE. That was the first paper and the results in the first paper. The second question that he asked is, what is the risk of recurrent VTE for patients who remain on anticoagulation? So We know that for those who are on anticoagulation, the risk is not zero, though, anticoagulation is very effective at decreasing the risk of recurrence. So again, inclusion criteria were just RCTs and prospective cohort studies. This was published in the Journal of Thrombosis and Hemostasis in August of 2021. Again, looking at provoked or minor transient risk factors. And the patients included in the study had to have received oral anticoagulant for at least 6 months after completing the initial 3 months of primary treatment. The primary outcome was, again, recurrent VTE while on oral anticoagulation. And for this systematic review, they were able to include 26 studies, 14 of which were RCTs, and about 15,000 patients overall. By the year 3 to 5 interval, we can see there were only about 4 studies that continued to be included. They did divide it up, we can see here, by VKA versus direct oral anticoagulant, but I will note here that we do not have sufficient data, unfortunately, to do any analyses past the 1-year mark for direct oral anticoagulants, despite the fact that we've had oral anticoagulants around for quite some time. What they found was that the overall event rate per 100 person years of recurrent VTE was 1.55 for VKA and 1.08 for DOACs. What is different between this paper, so for patients who are on oral anticoagulant, compared to the first paper that was presented and written by Faizan Khan, which is for patients who are off anticoagulation, is we can see that the rate of recurrent VTE does not really change between years 1 and 5. So 1.73 in the first year, 1.92 in the second year, and between 1.32 for years 3 to 5. Similarly, the rates of fatal PE, 0.11 for year 1, 0 for year 2, and 0.38 for years 3 to 5. So there is some variability there, but because of the small numbers, it's hard to say if this is true. The overall 5-year cumulative incidence was 7.4% in patients with VKA, with a fatal PE rate of 1.2% here. For patients on direct oral anticoagulants, the overall was 1.08, like I said before, with fatal PEs being 0.09 per 100 patient years. With those numbers, the case fatality rate for VKA was 4.2%, and for DOACs was 7.3%, with a pooled of 4.9%. And it was interesting to see that DOACs was higher than VKA here. It was theorized that potentially because this was due to the fact that you didn't have reversal agents, but because of the limited studies that were available past year 1, it could have just been as a result of sort of less information and less data as well. As a reminder, for those who are off anticoagulation, the number was quite comparable for the case fatality rate for recurrent VTE, which was 4%. So in his discussion, he wanted to make a few points. So first, like I said before, unlike in the first paper, where there was a decreased risk of, or decreased incidence of recurrent VTE for patients as they proceeded through time off anticoagulation, patients who were on anticoagulation had a similar risk of recurrence as they continued on anticoagulation during extended anticoagulation. In terms of the estimated risk reduction of recurrent VTE during extended anticoagulation, so for year 1, 8.6 fewer events per 100 persons with a VKA and 9.2 fewer events per 100 persons for a DOAC. And these values are in line with the relative risk reductions documented in RCTs previously, evaluating the benefits of extended anticoagulation versus placebo. In terms of the year 5 cumulative, we can expect, based on the numbers from these 2 papers alone, that there are 17.8 fewer events per 100 persons on VKA. So quite a significant protective impact at looking at the 5-year cumulative effect. In terms of the limitations, there is very limited DOAC data beyond 1 year. And therefore, given the fact that we're using DOACs a lot more commonly, the applicability may be a little more challenging, a little more limited. And in addition, there was 11 studies that did not have a definition for fatal PE, and 13 of the 15 studies that provide a definition for fatal PE classified unexplained deaths as PE related, which meant that the estimates for the incidence of fatal PE may have been a little bit high or exaggerated. All right, so the next question that was raised was, what is the risk of bleeding? So now that those first papers were looking at the risk of recurrent VTE, and these next two papers are going to be looking at the risk of bleeding for patients who are on therapy or not on therapy. So first, for those who are on indefinite anticoagulation, this paper was published in the Annals of Internal Medicine, Annals of Internal Medicine in 2021. Called Long-Term Risk for Major Bleeding During Extended Oral Anticoagulant Therapy for First Unprovoked Venous Thromboembolism. It included 14 RCTs and 13 cohort studies, and overall, a very large cohort, about 17,000 patients. So about 10,000 who received VKA and 7,000 who received a DOAC. Inclusion criteria-wise, provoked or minimal provoking factors, minimum 6 months of additional treatment after the initial 3 months of anticoagulation. And again, very limited data beyond the first year. What they found was the instance of major bleeding, so the ISTH definition, so, less than, requiring transfusion, greater than 20 hemoglobin drop, or into a critical space, was 1.74 events with VKAs and 1.12 events with DOACs. And that's, again, per patient, per 100 patient years. Looking a little bit more in depth into that data. So again, we only have 1 year of data for the DOACs, and for VKA, we have up to 5 years of data. We can see that the 5-year estimate for bleeding based on VKA alone was about 6.3% for major bleeding, 1.6% for intracranial bleeding, and 1% for fatal bleeding risk. And with that, that meant there was a significantly higher case fatality rate of major bleeding when compared to fatal VTE for recurrence of VTE. Looking at the data per 100 patient years, we can see that it is quite similar through time. So for VKA, 1.74 overall, 2 for year 1, 1.65 for year 2, and 0.95 for years 3 to 5. Whereas for DOACs, we really only have data for year 1, which is 1.20, and 1.12 overall, because they had a little data extending mildly beyond 1 year. In terms of fatal bleeding, we can see that it is overall 0.16 for VKA, 0.10 for DOAC, and sort of stays around that range throughout years 1 to 5. This chart here, I just want to show the amount of data they had for direct oral anticoagulants after the first year. So as mentioned, there was minimal data for bleeding risk in DOACs after year 1. And in the data available though, so this is based on Zalia-Leah, and a Wells study done in 2020. Overall, they had about 100 patient years for year 2 and about 50 for years 3 to 5. And of all those years, there was actually 0 bleeding events. So it's very interesting. We don't have very much data, much less for sure than the years previous, but very good indication that there probably is a low bleeding risk for those years on a DOAC. They did a further sub-analysis, which I think is super important for the purpose of understanding how to make decisions in regards to anticoagulation for prolonged periods of time. And they were trying to figure out what were the factors that were associated with a higher risk of major bleeding. And what they found was that in patients treated with VKA, female sex was associated with a higher risk of bleeding. And then for both VKA and DOAC, age greater than 65, reduced renal function, history of bleeding, concomitant antiplatelet use, as well as an initial hemoglobin of less than 100, were both highly predictive of major bleeding. And we can see here that for the DOACs, having a history of bleeding was associated with almost a 20 times risk of major bleeding. Same with concomitant antiplatelet use with a hazard ratio of, a relative risk of 17.18, and a hemoglobin level less than 100 having a relative risk ratio of 17.41. So these are quite significant looking at DOACs and their relative risk of resulting in increased risk of major bleeding when compared to patients who are not on a blood thinner or do not have these risk factors. So in terms of the discussion, after this paper was, the discussion around this paper. So what does this mean in terms of how decision-making and extended anticoagulation? So at 5 years, comparing the data for patients for risk of recurrent VTE versus risk of major bleeding, we can see that the risk of death for recurrent VTE at 5 years is about 1% for those who had anticoagulation discontinued. And for those who had anticoagulation continued, the risk of death from major bleeding was comparable at about 1%. So at the 5-year mark, you sort of have an even risk if continued on anticoagulation of death from VTE versus death from major bleeding. At 10 years, we don't have data for risk of bleeding, but if we were to estimate a moderate risk of bleeding, which they approximate in this paper to be about 3% per year. For anticoagulation, if it is discontinued, we found that the risk of death for recurrent VTE was 1.5%, but calculated a risk of death from major bleeding to be 2.4%. So it becomes very critical at this point to figure out sort of for patients who are going to be on indefinite anticoagulation, what their true risk of bleeding may be. And Kahn's argument ultimately was that because the case fatality rate for major bleeding is 2 to 3 times higher than that of recurrent VTE, it is proposed that patients with a major bleeding risk of 3% or higher per year be classified as high risk and thus not be considered for indefinite anticoagulation, regardless of their risk of recurrent VTE. And we can talk about that more in the future in regards to if you agree or what you think should be, or what you would propose to be a better model for determining who should be on long-term anticoagulation. Given this presumption or this conclusion that was made by Faison Kahn, I think an important question is, are these case fatality rates correct? And especially for DOACs, because there was very limited data that was available. And from other data that we've seen, other systematic reviews seem to have compared DOACs to warfarin and found actually a lower bleeding risk and a lower case fatality risk with DOACs compared to warfarin, which is not consistent with what we saw in Faison Kahn's paper. Given the lack of long-term data for DOACs, I think it's challenging to know what the case fatality rate for patients who experience major bleeding is, but I thought we would do a little bit of a dig into some other paper, or just one other paper, just to see how it compares to some other literature. So doing a quick aside, I want to look at a paper written by C. Chai Adisakova that was only looking at RCTs. This was published in 2015, and they were looking directly at RCTs that were comparing DOACs to warfarin. And this is not specific only to VTE. So it's looking at VTE or atrial fibrillation. And specifically, they were looking at case fatality rate of ISTH major bleeding and incidence of fatal bleeding. Secondary outcome was also all-cause mortality. And this was quite a large systematic review. So it included 13 RCTs, 58,000 patients treated with DOAC, and 44,000 patients treated with VKA. They were treated for a prolonged duration, so 6 months to 30 months, and they had very good agreement between the different papers. So this is an overview of the papers that were included. You can see that a little bit more than 50% of the papers were looking at VTE, and about 5 of the papers were looking at atrial fibrillation. Very large papers that were included, and many of which we are very familiar with at this time. And in terms of follow-up duration, we can see that it ranged from 6 months, like previously mentioned, to about 33.6 months, with many papers looking at durations greater than 12 months. The case fatality rate for major bleeding in this paper was found to be lower for DOACs than warfarin, so 7.57% for DOACs and 11.05% for warfarin. And the reason I think it's helpful to look at this versus the other data from Kahn is because this is only looking at papers that directly compare DOACs to warfarin. The rate of fatal bleeding was lower in DOACs compared to warfarin here, and DOACs were associated with a significant reduction in fatal bleeding when compared to warfarin with an RR of 0.53. And so, these are just the forest plots looking at case fatality rate for major bleeding and those who received DOAC compared to case fatality rate for those who received warfarin. And we can see it is lower for DOACs compared to warfarin in this study. This does bring to question whether or not potentially because of the limited long-term data available for DOACs, if that did potentially skew the case fatality rates for DOACs in phase and cons studies. All right, so now the final question that was raised by Faison Khan and his team was, what is the risk of bleeding in patients with unprovoked VTE who are not on anticoagulation? And again, we know that patients who are not on anticoagulation also bleed. So helpful to get an approximation of what that risk of bleeding is in these patients to understand truly what the incremental risk is of bleeding for patients who are on anticoagulation. So they had 17 RCTs and 3 prospective cohort studies for this paper. This was published in Thrombosis and Hemostasis in 2022. Again, same patient population, so provoked or minimal provoking factors, completed at least 3 months of additional anticoagulation, and excluded if they had a major transient or persistent risk factor. And what they found in this study was that the overall risk of major bleeding per 100 patient years was 0.35, with a fatal bleeding occurring in 0.09 per 100 patient years. The 5-year cumulative incidence was 1%. So it is a low risk, but it is a risk that is present. And we can see here, for whatever reason, there does seem to be some decreasing major bleeding as we go through time. So 0.44 in first year, 0.28 in second year, and 0.1 in years at 0 to 1. In terms of the bleeding case fatality, there was quite a bit of heterogeneity in the different papers we can see here. So this, again, all the papers that were included in this study, as well as their case fatality rates. And we can see the overall was 19.9%. And in comparison to the prior paper, which was looking at case fatality in patients who were on anticoagulation, it was about double for the patients that were on VKA or DOAC. So, whether or not we truly believe all of these results, I think we always have to continue to question and continue to wonder, because we wouldn't typically expect the bleeding fatality would be higher in those not on anticoagulation compared to those on anticoagulation. To summarize the 4 papers that were mentioned before, so number 1, looking at recurrent VTE risk and PE mortality. So I sort of put all those first 2 papers together in this chart here. And we can see that we don't have an overall number for no oral anticoagulation because it does seem to change quite dramatically with time. But in the first year, we reduced 8.6 events per 100 person years, 4.4 in the second year, and 2.5 in years 3 to 5 per year in regards to recurrent VTE on VKA, and 9.2 in year 1 for patients who are on DOAC. Given these concurrent case fatality rates for VTE, that means that in year 1, we would estimate 0.36 of decreased mortality per 100 patient years, and in years 3 to 5, 0.011 events in terms of reduced mortality per 100 patient years. And for DOACs, 0.67 per 100 patient years in year 1. Comparing the second 2 papers, looking at the major bleeding risk and how much bleeding you are incurring as a result of being on an oral anticoagulant. So the third paper is looking at the numbers here, and the 4th sort of with no oral anticoagulation. We can see that overall, the risk of bleeding does seem to decrease with time, with first year being 1.56 and years 3 to 5 being 0.85 in regards to the amount of incremental bleeding per year or per 100 person years. that occurs as a result of being on oral anticoagulation. And we do see these numbers are much smaller than the numbers that we see for reduced VTE, but of course that because of the higher case fatality rates, that does mean that we may have to put a higher emphasis on bleeding as compared to recurrent VTE. In terms of increased mortality from major bleeding, in association with these major bleeding, in association with these case fatality rates, we can see the numbers are quite comparable. So for VKA, 0.12 events per 100 patient years, for VKA's 0.0 events per 100 patient years. And they just have an overall here. And so if you compare to these numbers, slightly reduced, but, you know, comparable, and they're all quite small. In his final chapter of his thesis discussing oral anticoagulation or indefinite oral anticoagulation in unprovoked VTE, he created a probabilistic Markov model to simulate the cost and outcome. So basically he was trying to see, you know, in these two cohorts that he theoretically created, each 500 persons followed over a lifetime until either recurrent VTE, major bleed, PTS, CTEPH, or death, sort of what the overall outcomes were for these two cohorts, and sort of if there was a better scenario putting everyone on oral indefinite anticoagulation versus discontinuing after 3 to 6 months. He assumed in this model that he had created that at baseline, everyone started at 55 years old. For the indefinite anticoagulation arm, after recurrent VTE, patients were switched to low molecular weight heparin for 4 weeks, and after bleeding, anticoagulation was stopped for 2 weeks and then restarted afterwards. He did not specify directly in the paper what happened in the patients who had recurrent VTE while they were on recurrent VTE when they were off anticoagulation, but I can only presume that they must have started anticoagulation afterwards if they had a second unprovoked VTE event. These are all the inputs that they put in to his model, and they're all the same numbers that we saw in the previous papers. So, you know, about 10% risk of recurrent VTE in those with no anticoagulation, compared to 1% for those on anticoagulation here. And he did include in the model some, you know, average numbers for PTS, CTEPH based on other systematic reviews and meta-analyses that were completed previously. And what he found with these inputs was that if everybody was put on indefinite anticoagulation over a lifetime, it did result in fewer recurrent VTE as we would expect. So 139 out of 500 versus 392 with a number needed to treat of 4. But also increased major bleeding, as we would expect as well. So 144 versus 75 with an NNT of 15. However, economically, he did find that there were higher costs associated with indefinite anticoagulation, no improvement in quality-adjusted life years. And this was largely driven by the fact that there was a significantly higher annual risk of major bleeding during extended anticoagulation, and that the case fatality rate associated with major bleeding was much higher. Summarizing all of his information together, his final conclusion was that considering indefinite anticoagulation in all unselected patients with a first unprovoked VTE is unlikely to be either cost-effective or result in net clinical benefit, and that there was a need for a more personalized approach to deciding the duration of anticoagulation. So, after this, I sort of thought, do we agree with this overall? Is this data consistent with other data that we've seen previously? And what are the current methods for risk stratification of both recurrent VTE and bleeding? So the first question, like I said before, is what was the previous evidence for extended anticoagulation, and is it comparable? So I took a quick look at some of the other systematic reviews and meta-analysis that have been done. Most recently, this was published in Heart in 2019 by Wang et al. It was another meta-analysis that included RCTs only, comparing oral anticoagulants, aspirin, placebo observation, looking at recurrent VTE risk and major bleeding. They also looked at all-cause mortality, fatal recurrent VTE, and fatal bleeding, and included more than 22,000 patients through 16 studies. Looking at the pooled event rates, we can see a very similar rate of recurrent VTE compared to our paper. So compared to the numbers reported by Faison-Khan. So for those who are on placebo or observation, a risk of about 8.9% or 8.9 recurrent VTEs per 100 patient years with placebo or observation, 4.9 per 100 patient years on aspirin, and only 1.2 with VKA. For major bleeding, looking at placebo or observation, 0.3, and a higher risk with VKA of 1.2. So very similar numbers again to what we've seen in our papers, or in Faison-Khan's papers. This writing is very small, I apologize for that, but this is looking at recurrent VTE risk and major bleeding with the different types of oral anticoagulation. So we can see significantly reduced venous thromboembolism with direct thrombin inhibitors, so dabigatran, with standard dose factor Xa inhibitors, low dose factor Xa inhibitors, in fact, very similar between the two, standard intensity vitamin K antagonists. And these are all significantly lower than aspirin or than placebo or observation. With the odds ratios listed here, generally around 0.15 for all the different types of oral anticoagulation. Major bleeding, as expected, is higher with odds ratios of 1.38 to 4.42 for each of the different types of oral anticoagulation, which again, these numbers are quite similar to the numbers that we had reported in Faison-Khan's papers, with the lowest risk of major bleeding being in low dose factor Xa inhibitors here. So I think, again, this points to the fact that possibly Faison-Khan's numbers, because they don't include prolonged data for low dose factor Xa inhibitors, may actually overestimate the risk of bleeding compared to real world data that we hopefully will have in a few years. This is data from the same paper that was looking at fatal recurrent VTE and fatal bleeding. It's just comparing those two numbers. So for standard VKA, standard intensity VKA, we can see that there was an event rate per 100 patient years of 0.1, for low dose factor Xa inhibitor 0.05, and for standard dose factor Xa inhibitor 0.16. Compared to fatal bleeding, we can see that these rates of recurrent VTE, despite being on anticoagulation, are still much higher than the rates of fatal bleeding. And so, you know, it does seem that this paper continues to point towards benefit for being on anticoagulation compared to not being on anticoagulation. Again, data being limited to sort of up to about not much past 1 or 2 years for DOACs. And all-cause mortality with VKA or low-dose factor Xa compared to placebo or observation does seem to indicate that there is benefit from a mortality perspective compared to not being on anticoagulation, at least for the initial first years. Again, the limitation of this paper is that it does not extend beyond 1 year or break down the changes at the time, because as we've seen, the greatest benefit of being on anticoagulation seems to be the initial year or two after the patient is on, after the patient has either continued or discontinued. And so like the initial couple of years has the greatest increment in regards to benefit compared to the years after that. And of course, this paper was not limited only to patients with unprovoked VTE. The next question is, what do we expect will happen with major bleeding risk rates in DOACs past 1 year? Because again, Faison-Khan's papers, you know, he was only able to get data for up to 1 year due to the criteria that he had for his inclusion criteria and the available data that is currently out there. And so I was able to find this one paper that was published by Brandon Liu et al. In 2022 in Thrombosis Research. It was a 10-year review of sort of recurrence risk, fatality, bleeding, etc. In the warfarin era compared to the DOAC era. So he did both a era analysis looking at sort of 2011 to 2014 when warfarin was much more prevalent. So we can see here this transition from warfarin, which is in blue, to DOACs, which is in green, right, which transitions fairly significantly between 2014 and 2016. in the DOAC era, which has been 2016 and 2020. He also did an agent analysis looking at warfarin versus DOAC in regards to sort of the benefits of being on one or the other. So in terms of the actual patient data he included, so he did have about 50% of his patients did have unprovoked events, and he did include estrogen-related travel, surgery, and immobility under provoking factors. So those were all included within what was not included in Faison-Kahn's papers. Of note, about 5% of patients were not on anticoagulation. This differentiates the warfarin era versus the DOAC era. And we can see there were far fewer patients who were on no anticoagulation during the DOAC era, probably because of the ease of use of DOACs compared to warfarin. We can see there's a significant transition between the warfarin era and the DOAC era here, from about 80% warfarin to 70% DOACs between the two eras. And we can see that of all the patients that were included, about 20% were on indefinite anticoagulation, both in the warfarin era as well as in the DOAC era, with 12.8% of patients being on low-dose DOAC thromboprophylaxis in the DOAC era. So what were they able to actually find? So this is actually looking at the overall population. And after this, we'll look only at the population that was unprovoked. And they essentially found that there was a statistically significant reduction in bleeding in the DOAC era compared to the warfarin era, which we expected. Numerically reduced bleeding in the DOAC era compared to the warfarin era. No bleeding events seen in those on prophylactic doses, even though those who were on prophylactic doses were older. And there were 4 bleeding and 2 clot-related deaths during the long-term prevention phase. These here are the charts for major bleeding for the overall population. And with the multivariate analysis, you can see this statistically significant reduced bleeding in the DOAC era and the trend towards decreased bleeding in the long-term preventative treatment phase here. This is looking only at the first major unprovoked VTE population, so really our subgroup that we're most interested in. And though it is not statistically significant, we do see that numerically the hazard ratio is much lower for the DOAC era compared to the warfarin era. These two charts here are looking at major bleeding risks. And what we're really trying to get from here is sort of what if the risk of bleeding continues to be lower in DOACs compared to warfarin with time, because we don't have that data available with Faison-Kahn and his data. And we can see here that there was actually, so the 12-month mark is about here. And they have sparse amounts of data, but some data that extends to about 60 to 70 months. And we can see here that while patients continue to have major bleeding during the warfarin era, there was much less bleeding or very little bleeding in the DOAC era for patients who have been treated after about 12 months. So after about this initial period, there's very little further bleeding that happens. And they did note specifically in the paper that there's no bleeding that occurred on prophylactic DOAC or during the long-term preventative phase of the DOAC era. So I think this does indicate possibly that the bleeding values that were estimated by Kahn, because of the limited available data that he had, was overestimated. And of course, as expected, warfarin has a higher risk of significant bleeding complications compared to therapeutic DOAC, but with an overall and unprovoked VTE at 2.4 versus 1.4 events per 100 patient years. And this table just shows that, but we've seen that multiple times already. The takeaways from here, I think beyond 1 year, DOACs in the real world seem to continue to have lower rates of bleeding compared to warfarin, and therefore the bleeding rates reported by Faison-Kahn et al. May be overestimated due to limited DOAC data. So I spent quite a bit of time actually looking at risk stratification methods for recurrent VTE, but by the time I actually got to these slides, I realized that there was actually so much other data that we talked about. And I feel like this could be an entire presentation on its own. So there are I think basically what Faison-Kahn is saying is potentially we need to consider more risk stratification for recurrent VTE as well as for bleeding risk. HER2 is the main one that we often will refer to and look at because it is the one that is validated. I probably won't go into these too much just because of time, but essentially HER2 was published into the original paper for its when it was proposed was in 2008, multi-center prospective cohort study, about 646 patients. 600 patients completed a mean 18-month follow-up. And they found that men had a high risk of active recurrent 13.7%, and there was no predictors to stratify a low-risk subgroup that was defined as less than 3% in this group. But women could be stratified. So if they had post-traumatic signs, VIDAS, D-dimer greater than 250, while on warfarin still, BMI of greater than 30 or age greater than 65. If they had 2 or more of these findings, their annual risk was much higher, so 14% compared to 1.6% for those who had 0 or 1 of these characteristics. This was validated later on in 2018, a prospective international cohort study that was done, again, by Mark A. Roger et al. It included about 3,000 patients. 591 had a low-risk score for which anticoagulation was discontinued, and 1,534 men were included, 591 women with high-risk HER2 scores, and of these, 323 discontinued anticoagulation and 1,802 continued anticoagulation. And we can see here that the results are quite reassuring. So in those who are considered low risk, only a 3% risk of recurrent VTE, whereas those who discontinued oral anticoagulation, 8.1% risk of having a recurrence compared to 1.6% who continued oral anticoagulation. And this is per patient year of note. And for those who are high risk, women who discontinued oral anticoagulants specifically, their risk was 7.4%. And so we do see from this data here that the HER2 validation went quite well. And interestingly, specifically for those who are greater than 50 years old, there was a significant difference based on if they were on estrogen at the time of their index event or not. So if they were on estrogen and stopped, their recurrence risk was 0%. For those who are low risk, and for those who are not on estrogen, their risk of having recurrence was higher, 6.8%. So there was a significant difference there for those who are greater than 50. The limitations, as we all know, has been published multiple times, but there's poor correlation between the other D-dimer assays and VDAS D-dimer, and therefore this score cannot be reliably used for, in hospitals where they don't have this VDAS D-dimer test. Unfortunately, unless they have a score of 0, in which case you could say it would be 0 or 1. Methods for stratifying the risk of bleeding on oral anticoagulant. So, right now, based on the current guidelines, we have lists of risk factors that are associated with higher risks of bleeding. And in addition, from Faison Khan's paper, we do see there are certain factors that are associated with a high risk of bleeding as well. So that was that creatinine clearance less than 50, age greater than 65, hemoglobin less than 100, being on concomitant antiplatelet agents, or if you're on a VKA, being female, that were associated with a high risk of bleeding. But the question was, if there are better ways of stratifying the risk of bleeding on an oral anticoagulant to better allow us to determine, which patients are at a high risk of bleeding and for whom we should reconsider doing indefinite anticoagulation. This is a paper published in the European Journal of Internal Medicine in 2021, looking at the sensitivity and specificity of different bleeding risk scores in the context of VTE. And I did find that VTE bleed had the highest sensitivity at 76 or 0.76, meaning that, if you looked at all the patients who did have a bleed on anticoagulation and VTE, about 76% of them had a positive VTE bleed score as well. However, with the sacrifice, of course, is a lower specificity compared to some of the other papers, but the VTE bleed study does seem to have some more data compared to the other papers. Because of time limitations, I only very briefly went into it. It was derived in 2016. There are other good it has showed good predictive value when compared to the results of other studies as well, and looks at the main factors in association with higher bleeding, being active cancer, male with uncontrolled hypertension, anemia, history of bleeding, kidney dysfunction, and age of 60 years or older, with a VTE bleed score of greater than 2, or greater than or equal to 2, being equivalent to an instance of major bleeding of 12.6%, so higher risk. However, I think a lot more work could be done in regards to looking into validated scores for bleeding, as well as validated scores for evaluating risk of recurrence in patients who have had unprovoked VTE. So in conclusion, there was a whirlwind, so many numbers and so much data. So I'm happy to send like these tables out for reference later on if that is desired. But essentially, the incremental risk per patient year of major bleeding during extended anticoagulant therapy for VKAs is 1.39%, and for DOACs is 0.77%. So number need to harm is 72 for VKAs and 130 for DOACs. But this actually may be even lower, given that we've seen some data that indicates the risk of bleeding actually may be lower with time, especially on lower doses of DOACs or prophylactic doses of DOACs. For recurrent VTE, based on phase on cons data, VKA results in 1.55 events per 100 person years. DOACs, you can expect 1.08 events per 100 patient years, and off anticoagulation, that gradual decline going from 10.3 events per 100 patient years initially down to 3.1 in years 6 to 10. I think it is reasonable, given all this data, to consider careful consideration for indefinite therapy, especially for those with high risk of bleeding and low risk of recurrence, and keeping in mind those very high risk factors, especially for patients who are on DOACs, that predispose to more bleeding. So the creatinine clearance, the concomitant antiplatelet therapy, the older age, and the hemoglobin less than 100. Okay. Sorry that I rushed at the end. Thank you. And I'm happy to take questions or open the floor for discussion at this point.